it is my really great pleasure and honor to invite the great panelists. We have a wonderful group of 6 panelists who will be joining us to share their reflections, to share their views and experiences. We have several hospital directors, and I will be presenting them one by one by inviting them to share their own views. And if you allow me, I would like to start by Dr. Abdullah Al-Harthi, who is the Director General of Khawla Hospital in the Sultanate of Oman. So Dr. Harthi, if you can kindly share with us your experience as a hospital director, and in particular, how the hospital, Khawla Hospital, which is very well-known trauma hospital in Oman, has been responding to the pandemic, and what lessons have been learned, and in particular, what lessons for better future preparedness for any eventual pandemic or emergency of this nature, God forbid. Thank you very much. The floor is yours, Dr. Harthi.
Thank you very much. Assalamu alaikum, everyone, and Ramadan Kareem. Thank you for inviting me, and it's a pleasure meeting you guys, including my ex-boss, Dr. Ahmed Al-Mandari. I hope you guys are all well and safe. Since the beginning of the pandemic, we have been told that we are in the same boat. We keep hearing this phrase over and over again. However, we do realize that we are in the same storm together. However, each one of us is in a different boat, and each boat has its capabilities, its strengths, and its weaknesses. So I'm not a big supporter of that phrase that we are in the same boat. So as an institution, as you mentioned, Khawla Hospital is designated as a tertiary hospital in the capital region in Oman. It is a trauma center. It is also a stroke center for the northern part of the country. And in addition to that, we have a large obstetrical service. As you notice, most of the services I mentioned, 90% of them are surgical specialties. So COVID has been extremely challenging for us, which is a disease that is mainly treated by internists and physicians, not by surgeons. However, as we said, we're in it together. The strength of Khawla Hospital was that we had one of the largest intensive care units and most modern intensive care units in the country. The challenge was converting this surgically intensive or heavy intensive care unit to start thinking to cater to internal medicine patients. So some of the things that we did on the institutional level, of course, was trying to determine protocols and build protocols early on. We were lucky with regards to this pandemic, lucky for Oman, is that we could see this pandemic, the effects of this pandemic in countries like Iran and in Italy before we started our cases building up. And we could see the effects and stress it would place on the healthcare sector. So we had the opportunity to start building these protocols on how to triage these patients, which patients were we going to admit, which patients were going to be diverted to other institutions in the region, and if they reached their surge capacity, and therefore we were going to take the overspill from the other hospitals. Everybody kind of understood their role even before the cases started building up. So this was one of the graces that we had, alhamdulillah. We also tried to focus on the collaboration between the different specialties. We all used to work in silos, and we realized that this pandemic cannot be treated that way, either between institutions or between the specialities themselves. We also understood that COVID patients can come with specific needs, like they could be trauma COVID patients or obstetrical COVID patients or COVID patients with strokes. And therefore, we needed to know how we were going to cater to COVID patients who had specific needs. This required training and continuous retraining of staff. We understood that it would be very difficult to recruit new staff in such a short time. And therefore, we had to cut on the services that we were providing and relocate the staff. But you cannot take somebody who has been working for years in the orthopedic operating room and suddenly put them in the COVID ICU and expect them to function independently. This required us developing an expedited training program, and that we were quite successful, mostly on the nurses level than we were on the doctors level. It is quite difficult to train an orthopedic specialist to work as an intensivist. However, the nurses were much more flexible, more dedicated, and we're very proud of what we have done. The issue is that you cannot depend on just one course. You have to make sure that they keep going through it over and over again. And we took advantages when the COVID waves were dropping. Right now, we are in the midst of our third wave, the worst it has ever been. And actually, one of the challenges is that we have lost a significant number of our workforce, including the ones that we have trained, because they have either chosen to leave and seek employment opportunities in other ways, other places, or unfortunately, they have been burnt out and have decided to stop working in the healthcare industry. And unfortunately, I think that shows a little bit of a failure from our side to be able to support our staff. We have tried our best, as Dr. Hamid has mentioned, the rotation. However, when you have a lack in the number of staff, you cannot afford to take them out of the COVID ICU and bring less experienced nurses in that area. As it was mentioned, it is basically our resources is a piece of is a cake that we just keep slicing through and don't expect to have larger pieces just by cutting more and more into it. And therefore, we have had to unfortunately divert a lot of resources from the non-COVID patients to the COVID areas. And my fear is that this was acceptable in the beginning of this crisis in March 2020. Now we have completed more than a year and we are still doing it. Down the line, I think we will unfortunately see the effects that we have had on the services that we have had to cut. Hoping that this crisis ends soon and we can try to establish some kind of norm and catch up. But for example, my waiting list for some of my orthopedic cases is up to 2024 and it is still building up. One of the things we have learned, and please, if I do exceed my time, just tell me to stop, because hospital directors don't know how to stop. So
maybe you can go for 2 more minutes, please, and then we'll have more chance during the discussion.
Great, please. Great. So one of the things that I'd like to emphasize on is also investment in middle management. As I mentioned, we were very hierarchical. We used to work in silos. We felt that in addition to the hospitals getting autonomy from the Ministry of Health, working in collaboration, but given the flexibility to take its own decisions, depending on its capacity, its capabilities, its unique specialities that are there, and the fact what they are facing on the ground, us as a hospital, we had to invest in our middle management. And also we had to trust them that they were going to follow the strategy put by the hospital and that we could follow them later, but that we could not micromanage every situation, weekends, at night. They had to have that flexibility. I think I will stop right here. There's many issues like the fragility of the supply chain and all of that, but I think we can address that later.
Thank you very much, Dr. Harthi, for these insights. And thank you for being open with us with regard to the challenges that you have been facing at the hospital level. I very much appreciated your first point about learning from others and how some countries have been thankfully more privileged than others. They have observed what's happening elsewhere and they managed to capture the lessons from those experiences and trying to be better prepared facing the pandemic. You have highlighted the importance of collaboration. We have been always calling for the whole of government, whole of society approach, and it's great Dr. Maha Al-Adawi with us here, who has just contributed and led a commission on social terms of health, highlighting the importance of this having a multi-sectoral approach for health. So this is really a very important point. You have also highlighted the significant role and the major contribution of health workers, and thank you for emphasizing the contribution of nurses. I mean, last year we had announced it as the year of the nurse and the midwife. And this year, WHO has announced it as the year of health and care workers. to give credit to the important role that the health workforce has been playing in the pandemic, but also in ensuring the better functioning of the health system. And my last point that I would like to reiterate from your talk is the importance of the agility, and how you have been emphasizing that you could not recruit more staff, but you needed to build the capacity of the current staff to be able to cater for the needs imposed by the pandemic. And maybe with this, that would lead me to our second panelist, and in particular to talk about the agility that has been used by the Aga Khan University Hospital in responding to the pandemic. So I have the pleasure to invite Ms. Shagufta Hassan to share with us her experience and the experience of the Aga Khan University Hospital in the pandemic. So Ms. Hassan, the floor is yours. Thank you.
Thank you very much. Assalamu alaikum and Ramadan Kareem to all the people who are participating with us. Thank you for providing this opportunity to me to talk about what the experiences at the Aga Khan University Hospital were during the pandemic. Just for the interest of all, Aga Khan University Hospital is a not-for-profit hospital, and we are a teaching hospital that is Joint Commission International accredited. Pakistan is a country of 220 million people, and the city of Karachi, where this hospital is located, is 22 million people, which is larger than many countries of the world. Our ratio of hospital beds to 1,000 people is just 0.6. So we come from a country where there is not a very organized and very robust healthcare system. And so there is already a shortage of healthcare professionals, hospital beds, etc. So when the pandemic arrived and we started finding out about this, the entire world, including Pakistan, we had no knowledge of what this pandemic is going to look like, what it is going to be, what is going to be the duration, etc., etc. And so to begin with, it was a series of questions that were coming by the passage of the day, of which some answers were available and some answers were not available. And so what we have in the hospital is what we call a hospital incident command system. By the name, you would figure out that there's an incident command. So whenever there's an incident that happens in the city, in the country, this hospital incident command system, which is a multi-department system, it brings all the teams together, which includes the logistics team, the safety team, the medical team, the government relations team, the finance team together. So we activated that because we really did not know what this pandemic is going to be like. And so this system was implemented. Second biggest challenge was that we did not have any testing facility. And Alhamdulillah, Aga Khan University Hospital Clinical Laboratories is the only laboratory in the country that is College of American Pathologists accredited and JASCI accredited. So we worked on the development of the PCR test, and we were the first lab in the country to offer the PCR test. What that meant was a lot of pressure. And of course, we had limited capacity. So it was a lot of pressure for us to do the testing, not only for the patients who are coming to us, but from other hospitals and from the government. The other important challenge that we were faced with is the development of the protocols, whether we are talking about the testing protocol, the treatment protocol, the employee health safety protocol, the facilities protocols, the government and media relations protocols, and so on and so forth. So what we did was that we used this hospital incident command system and assigned responsibilities to the various teams who would go back and come up with the different plans. And the central hospital incident command system was the system where all the plans were discussed and where we would share the concerns, share the developments that are happening, and share the protocols that got developed. Another very important thing was, like, there was said before me, training of the staff, because we are a quaternary care hospital, but the staff was not trained to deal with a pandemic of this nature. So we trained, we retrained, and we kept training the staff who was on the front end, whether they are doctors, whether they are nurses, whether they are healthcare professionals, whether they are cleaners, whether they're security guards, because everyone who was in any form close to the COVID patients had to be trained. And we had the advantage of being the teaching hospital that we went training people. The other important challenge was that being a quaternary care hospital, we had other patients who were coming initially. And so we could not mix the COVID patients with any other patients. Therefore, we had to separate the facilities for COVID patients. And in very early during the pandemic, it took us a lot of effort to come up with areas which are separate air conditioning systems, separate buildings, separate entrance, separate exit for the COVID patients. And those changes to the facilities were done very early in the pandemic. And what we had done was that we designated a 110-bed facility for this purpose. This is a separate building with separate rooms, which is a private ward building. But we had to do this because initially it was not known whether the COVID patients can be put in a ward setting or do they require separate rooms. So we dedicated a private wing, which was a big revenue generation facility for us for this COVID patients. The other very, very important thing that happened was that, like the world, nobody knew how to deal with the patients or the pandemic. And so there was a lot of expectation of the Aga Khan University Hospital to provide support to the provincial government, to the national government. And for that, what we did was that whatever protocols were being developed for anything, for testing, for treatment, for PPE, for infection control, for cleaning, whatever it was, we went sharing it with the governments, not only the city government, but the provincial government in the province that we are present, but also the national level. So what we did was our learnings were being shared across the board with whoever could make use of. So we, being the teaching hospital, took the lead in that. And we even conducted virtual training for public sector hospital nurses, public sector hospital doctors. And we came up with a unique thing, which was to provide online consultation to ICU physicians who were providing care at the government sector facilities. So our ICU physician working in a distant city could call our physician, ICU physician here, and seek help for the treatment of the patient, which was a very, very great initiative, because sitting in Karachi up north, which is thousands of kilometers away, our physicians who are here were able to provide the protocols and care to people who are right up north. So it was a very, very important intervention. Communication to us was a very big challenge. Communication with the people within the institution, with people who are above us, with people who are reporting to us, but also communication with the public at large, our patients, our stakeholders. And so we had a media and communications team that was given this responsibility. As far as our teams was concerned, the hospital incident command system would meet 2 times a day. And what we would do is, from there, whatever is the change information would be disseminated in the form of a flyer, in the form of an audio recording to be released to everybody, or in the form of a town hall. So what we were doing was, this communication was critical to keep everyone up to the speed. And also, we were very fortunate that we were able to deploy technology very early in the game. So deployment of technology for Zoom meetings, for town halls, which were virtual, actually helped us to communicate our messages. What we also did was that we came up with an app to see how our employees were doing. And every employee, every 24 hours, has to submit their information through this app to tell us how they were physically doing and how their health is. Of course, there were safety concerns, negative pressure spaces, etc., had to be kept. But there was another thing in Pakistan, which was, like many other countries, we had a very strict lockdown. And of course, the lockdowns internationally and nationally were a big deterrent for us to be able to procure, whether it is PPE, whether it was testing reagents, whether it was sanitizers, whether it was construction material, medical surgical equipment, etc. But what we did was we started securing. And the one great thing that we did was that none of our staff, whether it is the housekeeper or the very senior physician, was allowed to enter a patient care area with COVID patients without the appropriate PPE. So it was our decision to keep all our staff fully protected and fully safe. In addition, the hospital took a very bold decision that the cost of the test, cost of the treatment of all the patients, all the employees and their families would be provided free of cost. So that was also a very big savior for us, that not only the healthcare worker who's up here who could get infected, but if their family also gets infected, we are providing them free of cost treatment. Our staff, like staff in many other hospitals, was infected. We had to find spaces to isolate them. We had to find spaces to quarantine them. Of course, it was a big challenge because we do not have such facilities. So, but we created them. Our students from the medical college and nursing school had to be sent home. So we used the student housing to convert into employee quarantine and isolation spaces. They ran short at one point in time, but we were able to create other spaces. In addition, being a private, not-for-profit hospital, we had a big financial challenge because we have to sustain ourselves. We do not get grants from anywhere. So what we did again was that all our patients disappeared. The moment COVID went up, the other patients went down. And the hospital, other than the COVID units and the emergency department where the patients were coming, the hospital started to look like a ghost town. But we took a very hard look at our expenses and we tried to curtail, and we actually curtailed all the discretionary spending. Our management was, and the leadership and our board of trustees was giving us the direction that we cannot lay off any employee. So we had to find attractive ways to keep the financial momentum going. And as the first wave started to go down, we worked on restoration of services and how does one make care safe for others? How does one give confidence to its patients to return back to the hospital? So a lot of work was done on safe care and return of patients to the hospital. Is my time over?
I think this is a great overview, great sharing of experience. We'll have more time during the panel, after the panel, during the panel question and answers. But thank you very much for sharing this experience with us, Mrs. Hassan. Sorry to cut you before the end of what you wanted to share.
No problem at all.
I very much appreciated, thank you again, appreciated your first remark about the incident command system. And I mean, from the first beginning of the pandemic, we have been observing the importance of this leadership in responding and in controlling the pandemic. We were talking about it at the macro level, at the state level, but even at the hospital level, it appears to be really a very important lesson learned about having a sort of a command system that in order to organize and in order to facilitate the response. It is also amazing to see how a private, non-for-profit, but a private hospital has been instrumental in the national response. And this is something that we have been observing. Several different countries have been having different experiences with regard to the role of the private sector. But we can see how a private hospital, non-for-profit one, has been very much involved in the response. Thank you for raising the importance of technology and how you were able to incorporate innovations into the response. We observed that many of the things that we have been calling for promoting were difficult to be accepted by countries, by providers, by practitioners. However, the pandemic has pushed many to introduce and to incorporate and to adapt and adopt such innovation. So this is something that is really a lesson learned for the future. My last point, which is your very first point that you have mentioned, Mrs. Hassan, is that the starting point also plays a very important role. I mean, you were referring to a fragile health system in the country, and that has impacted the extent of the pandemic. And this for me is a very important lesson for the future: how to strengthen the health system, how to ensure that we have resilient health system with better preparedness in order to be prepared for any eventual emergency of the future. With this, I would like to move to our third panelist, coming from the Islamic Republic of Iran. So Dr. Nader Tabakuli, he's the Vice Chancellor of Curative Affairs at Iran University Medical Sciences. So again, the same question, Dr. Tabakuli, can you kindly share with us your experience talking about the Iran University Medical Sciences and the hospital experience, but maybe going wider at the prevention level. The floor is yours, Dr. Tabakuli. Again, 5 minutes. Thank you.
In the name of God, hello to everybody. My pleasure for participating to this very interesting session, and thank you very much from our colleagues, and thank you from Mr. Al-Mandari, Regional Advisor and the Regional Director, and Dr. Hamid Rawaqi for good coordination and other persons. we nowadays are in the peak of the pandemic, fourth peak of the pandemic in Iran. Unfortunately, we have high burden of disease nowadays, and in Tehran metropolitan city, one of the best experience was that the commanding in Tehran metropolitan city about the coronavirus operation was unified, and 3 universities have one EOC for commanding, coordinating, and other issues to hospital managers. In Tehran, we have 175 hospitals, governmental and non-governmental hospitals in the Tehran. Now, more than 100 hospitals involved in the COVID-19 management. We have very good experience, especially in fourth peak that nowadays we are involved in, was outpatient management of COVID-19 patient in hospitals according to Ministry of Health clinical practice guideline for parenteral treatment of the patient. After evaluation of patient, we find that 2/3 of admitted patient or inpatient in hospitals are non-critical, with hospital stay between 5 to 10 days, and they have good condition, and they are in hospital for treatment, parenteral treatment. According this guideline, we implement and develop some clinic and daycare clinics in special parts of hospitals. And this experience include 2 type of patient. One patient that have 1 or 2 days after the hospital stay and have good experience, good condition with good after evaluation with a special physician, they discharge to home and come back for daily treatment, parenteral treatment, and with this protocol, our result was very amazing. During last week, we have 11,500 cases that manage with this protocol, and every day we reduce 1,064 patients not admitted in the hospitals. And insurance system was approved for covering this patient. And nowadays we are trying to continue of care to home care protocols that it was a very good management for patient, and in the area of surge capacity in the hospitals can reduce need of increasing hospital beds. This experience, very good experience for our emergency operations center. Other experience we have in the hospitals, bed management and discharge teams that ongoing assessment of patient and for best efficacy of the beds. So discharge become accelerated in the hospitals, and we have very good discharge team. These teams include one special physician and one of the director of hospitals and nursing management that try to discharge the patient. And one of the other good experience was use of telemedicine in high-risk pregnancies. every day we have consulting with special obstetric specialty in the area that COVID-19 pregnant patient cover in the home, and we have one center in the hospital, in the university hospital, for managing these patients. Another a good experience was where electronic triage system in all hospitals that we have in the hospitals, that so for admitting the patient, it was very good system. Another good experience was that change of care to main general hospitals. So surge capacity directly in this hospital was very good strategy, because specialty hospitals have not enough system for covering the patients. And we try to cover the patient in the different hospitals, between hospitals, all private and general hospitals, that we have, we don't go into the mobile hospitals or other mobile hospital solution. So we try to best efficacy, try to implement best efficacy in the hospital beds. Thank you very much for this session, and at the end, I try to develop and advise this clinical practice guideline for outpatient management that we have in the university and all the university in the Iran. Thank you very much.
Thank you very much, Dr. Tabakuli, and thank you indeed for all the efforts that you have been exercising at the level of the Iran University of Medical Sciences, but also coordinating with other tertiary hospitals in Tehran and in the country at large. Again, you have highlighted the importance of telemedicine, and this echoes the point that was given by Mrs. Hassan with regard to introducing technology in the response. This is something that we are learning from, and I guess it will become part of our regular practice moving forward. I very much appreciated your reference to the discharge team, having a multidisciplinary team to evaluate the patient before being discharged from the hospital. I mean, at one point we were discussing who is the one who would be considered as recovered from COVID and hence could be discharged from a hospital, and that really requires a multidisciplinary team to be able to assess the situation. I very much appreciated your reference to the change in the patient flow, directing patients more towards general hospitals in order to cope with the surge in demand for tertiary hospitals. And I guess this is one of the guidelines that we have been providing in order to ensure the maintenance of essential health services. So even not only for COVID patients, but for patients who are suffering from other conditions and who are in need for other types of services, how the flow of patients have changed. We have observed that sometimes some complicated cases started going towards primary health care because patients were worried to go to hospitals because of the fear of infection, but also because hospitals have been were overwhelmed by their limited capacity. Again, on behalf of myself and all my colleagues, we would like to thank you as a chancellor and of the capital of the country that has been affected the most by this unfortunate pandemic. And you have been doing great work, and really we are very much appreciative for all of this effort. With this, I would like to move to our fourth panelist, Dr. Ali Sabatin, who is the head of Infectious Diseases Unit at Augusta Victoria Hospital in Jerusalem in Palestine. So Dr. Sabatin, the same question, if you can kindly share with us the experience of Augusta Victoria Hospital, what lessons learned, especially that Augusta Victoria Hospital is the well-known cancer hospital in the country. It is how did you manage to cope with the demand for the cancer care along with the response to the pandemic, and any lessons that you would like to share with us? Dr. Sabatin, the floor is yours.
ببخشید فلسطینه بعدی سودان.
Yes, Palestine.
Yes,
Assalamu alaikum. Hi, everybody. I'm talking to you from Jerusalem, from East Jerusalem, as you mentioned, from Augusta Victoria Hospital. Yes, it is a special hospital because we are dealing with immunocompromised patients. The hospital is located, as I mentioned, in the East Jerusalem, and we have almost 130 beds. We are serving the immunocompromised, I mean, oncology patients, hemato-oncology, pediatric and adult, in addition to the dialysis patients, also pediatric and adult. The hospital, from the strength point of view, is accredited for the third time for GCI. Joint Commission International Accreditation that give us opportunity to be ready as Infection Control Committee and Infectious Disease Department to deal with the influx and with the epidemiology, as it one of the requirement of the GCI to be ready. I will focus on the steps that were taken by the Augusta Victoria Hospital to manage and to deal with the outbreak and the epidemiology at that time. First of all, as was mentioned before, we established a committee, which is very important committee, which is Incident Command Group. And I will not focus a lot about this committee, but it was mentioned. So after the established this group, Incident Command Group, we divided our work for three things. We focused on the first thing, on the staff. Second thing on procurement, and third, the communication between and processing between all these things. Regarding the staff, we worked hard with the staff before even coming cases to the Palestine, as we had good communication and we were exposed to what happened in around us in the world. So we started to prepare ourselves before even first case was announced in Palestine, with preparing our staff and preparing our homework regarding the case definition, and we did the drill several times. Suppose that the patient come with suspected case from China or from infected areas. Training was on screening patients to identify the possible close contact with cases or possible patients themselves with signs and symptoms. And we draw and write the pathway, clear pathway for the healthcare providers to know how to deal with these cases. Also, we started to train our staff how to do donning and doffing. All our staff, including doctors, nurses, cleaners, all, we give them training how to do donning and doffing, because you don't know who you will use at that time. The things that was helped us a lot, that at the first case was announced at the Bethlehem at that time in our country, we established the preparedness plan that we already prepared, and we started doing all steps that we already agreed on. Our big challenge that also was identify the cases. So we started also to establish a laboratory that can identify the cases by PCR, and we were the first in the country that we can do PCR as a private hospital, and that helped us a lot in managing the cases and doing triage, as well as because we will have the answer of PCR after 3 to 4 hours of taking the swab. Regarding the second point, I talked about the staff and training the staff. The second point, procurements. Also before the lockdown and before the cases were announced in the Palestine, we started collecting all necessary PPEs from the possible market in the Palestine, and we never had any problem with PPEs at the time of outbreak. Although we were the very, I mean, we were well trained as a staff and prepared ourselves, we were the first hospital that identify cases in hospital with COVID, and that was a big challenge because we had prepared ourselves well, and we can catch. And we were the first who catch patients in the hospitals, and that was a big challenge because that was, this was a lot of challenge. First hospital with the COVID patients and how to deal with other hospital, and the main challenge for us at that time was how to provide safe services and therapy for other patients. I mean, oncology patients. You cannot stop the chemotherapy cycles. You cannot stop radiotherapy and dialysis patient. So we worked hard at this point to manage and to provide those patients and to continue their protocol, to continue their sessions of dialysis as usual. And we success with that by those steps that were taken. We also reduce the load of hospital by reducing to reduce the risk of infection and better manage health worker. When you decrease the capacity for example, surgery, we postpone all elective surgeries, and at that time we can manage and manipulate the healthcare workers from one department to another, and we can do better in facing this outbreak. We also postpone and stop all outpatient clinic, and we postpone all non-urgent hospital admissions. We as Palestine, we are under occupation, and this is also another challenge for us because there was difficult for our patients to cross the checkpoints every day. So we decided to accommodate our patients in the hospital, and that require for chemotherapy patients, radiotherapy patients who are receiving therapy on daily basis, also for the patients who are on dialysis, mainly from the hotspots at that time areas, I mean Bethlehem, where cases were discovered. So we provide them with the AVH TOC responsibility for their accommodation and booked them hotels in Jerusalem to facilitate access to the hospital easy. Regarding the other step that we were taken at that time, we divided our team for 14-14. That's mean 14 days duration work. Then this team with 14 days will be changed with another 14 days team to in the case if we have any case of among those staff affected, you know whom you need to quarantine, to send home, and not to that will keep your staff more available in the hospital, and you can deal with this situation better. And also that helped us a lot with this situation. Effective communication, we had a lot, we have effective communication internally between the staff, between the administration, between all departments, and externally with the Ministry of Health. And we reported cases on daily basis, that was diagnosed by Augusta Victoria to the Ministry of Health. As well, we were with a good relationship with Minister of Health to know what is the situation outside of the hospital. So I just mean also I want to say how we did screen our patients before coming to our hospital, and we screened on 3 steps. First of the steps that talking to the by phone to the patients 1 day before coming to the hospital, ensuring that there is no symptoms and there is no contact with sick patients. The second things, before coming to the hospital in the bus, we send a nurse to collect patients in the bus and to do screening during transferring those patients to a hospital. And that other third one, when they come and enter the hospital, screening, the third step of screening. We established the area for suspected patients and area for confirmed cases. In the suspected cases, we took history and took the PCR, waiting for the result. If everything is okay, we send the patient to the department as usually. If not, send them to the either home or to the department was for the COVID patients. The lesson learned from our experience, I think that the support leadership and clear coordination was very important for us, and it helped a lot in that step. Also, we took a multidisciplinary approach and in decision making. The establishment of COVID committee, as was mentioned before, and the clear communication between the team themselves helped us to go through this outbreak very well. And the last things, we now post-COVID, I think we are not now a post-COVID era, as we give our staff, all staff, vaccination, and now we are give a vaccination for our patients as well. Thank you.
Thank you. Thank you very much, Dr. Sabatin. This is, again, a wonderful example that you are sharing with us. I very much appreciated your reference to the importance of preparedness and how the hospital has started early on to be prepared for the eventual increase and surge in demand for hospital care. In the next upcoming, inshallah, regional committee, we are working on a paper on how to strengthen preparedness at the health system level and at facility level. So we're looking forward to learning more from the experience of Augusta Victoria Hospital to inform the paper that is being developed. But I also appreciated your reference to the training of the staff and how you have focused on donning and doffing, and how that has contributed to the sufficient availability or the lack of shortage of PPEs in the hospital. So this is something that the hospital should be proud about, and we are very proud of. Indeed, that you managed to do that, despite the fact that it's a hospital of a high risk, in a sense that the patients, as you mentioned initially, are immunocompromised, and you have high risk patients. Yet there has been proper control through proper infection prevention and control measures. I guess the approach that you have taken of the 14+14, I think this is one of the innovations that worth being further documented and further studied. We listened previously to a private hospital from Aga Khan University. You are a non-governmental organization hospital. Again, this emphasizes the need of whole of society, whole of government, of proper coordination and collaboration across all sectors in responding to a pandemic like the one that we are living it through. My last take from your speech, you referred to occupation as being another challenge. I think, and maybe I am biased here, but I think this might be the main challenge that the hospital is faced with, especially for a tertiary hospital where people are not having the easy access for, despite the fact that it is one of the key referral hospitals in the country. But you have been doing great despite all of these challenges, and thank you very much for your effort and the efforts of all your colleagues. Now we'll come to our next panelist, Dr. Yasin Omar, who is coming from Sudan, and he's he's responsible for the National Steering Committee and has been spearheading the isolation command centers in Sudan. So, Dr. Omar, we would like to listen from you as well about your experience, the experience of Sudan in facing the pandemic. We are just coming back from a mission that was led by our Director of Program Management, Dr. Anna Hajer, to whom we will be listening soon in Sudan. And we very much enjoyed the hospitality first, but also the great effort that is being done by everyone in Sudan in the response to the pandemic. So, Dr. Omar, the floor is yours.
Hello, everyone. Assalamu alaikum wa rahmatullah. Ramadan Kareem. First of all, it is a pleasure and an honor to be with you here on this webinar. And I'm very happy to be presenting our experience with COVID response in Sudan. First of all, just as a bit of a background, Sudan is a country of 42 million as a population, the capital of which is Khartoum, which has about half of that, about 20 million. The bulk of our cases is actually centered as we speak in the capital, which is the state of Khartoum. But also we are currently in a transitional period of a new government in place. The consequence of that is 30 years of the past government was there was chronic underfunding and mismanagement of the health sector. The health was not put as a priority on the national agenda, and hopefully with the new transitional government and with the new hopefully elected government, it's going to be one of the highest priorities. With that being mentioned, that reflected on our hospital environment as a poor hospital infrastructure, poor staffing of hospitals, poor systems in place, poor supply chain systems, as a result of chronic neglect over more than 3 decades. So when we came in, our first case of COVID was in March of last year. The state was that there was a state of panic amongst all healthcare workers because of all of the rhetoric in the media, and there was very little scientific material circulating at the time about COVID. A lot of the healthcare staff was frightened, and it was a state of panic across the board. And when you have weak systems in place, there's no safety valve for that panic against the patients. So what ends up happening is what we had was a state of panic amongst hospital managers, amongst senior healthcare providers and senior healthcare workers, and the tendency and an unwillingness to cater to COVID patients. So the Ministry of Health at the time started its response through training for all of the healthcare workers involved in the capital, and teams were sent to 17 other states to train on, to remove some of the stigma of COVID from our healthcare workers themselves, and to train them on IPC measures and facility redesign on how to protect their hospitals and how to protect their institutions and how to protect and how to put IPC measures in place, whether they be physical or mechanisms of PPE and ventilation, and to help improve their hospital infrastructure with the available resources at the time. So it gives, it protects our patients and also gives the sense of security to staff. It also, the role was, the Ministry of Health lobbied the other sectors of the government to provide incentives for the staff, whether they be financial incentives, whether they be in the form of recognition, whether they be in the form of universal health coverage for the staff in case they fell ill because they felt that the system would not protect them, in case the staff or their families were to fall ill with a disease that they would be fully catered for and would be given priority in treatment. Also, they lobbied the other sectors of government to provide residences for the staff because there was a tendency of fear that the staff wouldn't want to go back home. It also started a national process of recruitment across the capital and across all of the states to recruit new staff, nurses, doctors, IPCs, psychologists, to staff the COVID service so as not to disrupt the non-COVID service as much as possible. Part of the past system was, unfortunately, our hospitals don't have permanent staff. Hospitals depend on senior specialists as permanent staff, but the rest of the healthcare team would be rotating staff of trainees, of residents, of junior interns. So the disruption in that disruption caused a lot of the staff that didn't have actual contracts with the hospital or actual commitments with the hospital to be unwilling to work with that contractual obligation. So that was something that we tried to repair very early on in the pandemic, and I think we had a fairly good degree of success in that matter. We also worked on training for the capital and for the 17 states. We dispatched teams, as I mentioned, to train on all of on the IPC, on the case management, on the critical management, critical care management for COVID patients, and to build capacity of emergency care management as well. And also to put to work on facility redesign on all of the hospitals. And also that teams that were dispatched still had connections with the team. It was TOT training, so we still have connections with the focal points that they've trained in every hospital, and they make sure that there's continuous rollout and continuous medical education in each of these hospitals. and with a reference point back centrally. So any issues that arise or any questions that arise, they have that support network centrally to provide them with the senior consultation, the senior advice. And it's also around that time was the decision of the ministry to form a new management system, which was called the Isolation Command Center. The reason to form that it's a new directorate under the Curative Medicine Directorate at a state level, at the state of Khartoum level. The reason was there wasn't enough managerial capacity within the Ministry of Health, whether at a federal level or at a state level, to deal with a pandemic such as COVID. It's a new government. They're still getting the hang of things. The past government really neglected middle management and neglected to build the capacity of middle management and lower management. So they formed this new administration to be responsible for everything COVID within the ministry, so it can free up the ministry's time to make sure that other non-COVID services are not disrupted, whether it be the vaccination programs, other hospital functions. So that's the reason to form this new directorate of the Isolation Command Center. Also, through the Isolation Command Center, it's reflected on a federal level, where it participates in writing the National Case Management Protocol and the National IPC Protocol for COVID. So it's a very good bilateral relationship where the ICC has a network of frontliners that reflect what's actually going on the ground, because before there was a disparity between the clinicians manning hospitals and between the Ministry of Health and the public health practitioners. There was this gap, and we were very fortunate that we were able to bridge that gap in the COVID response, where the frontliners reflect back to the Ministry of Health what actually is going on the ground, and the Ministry of Health puts appropriate protocols based on that reflection, and guides the response nationally based on the ground reflections. We also implemented an online registry system for all of the patients, an online registry and referral system for all of the patients within the capital. So any patient that presents to a hospital with a primary isolation area for COVID is immediately uploaded on an online registry, and the patient is put there, and through that system is the patient referred to a tertiary or a secondary facility for COVID, which is a bigger hospital dedicated for COVID with bigger critical care capacity, with all of the different departments that a COVID patient will need. So it also thankfully covered one of the main gaps that we had, which was data. We've always had an issue with data at a ministerial level and at a hospital level. So this online registry system served the function that any patient that's ever been in the capital with COVID is registered. So we know exactly and the registry has the clinical profile as well, which is also helpful to guide the resource allocation and the bed planning and bed management for the future. It also took care of the partnerships with the different stakeholders, whether it be the private sector and the different NGOs. The private sector has been under-regulated for a long time in my country, but fortunately with COVID, it was a very good bilateral partnership where the private sector contributed in a lot of the financing of the COVID service, which also brings me to the point that for the first time in the history of the health system in Sudan, the COVID service is free of charge. It used to be 80% of our health system, or 80% of the care is out-of-pocket expenditure for the patient. We tried within COVID because it's a national emergency to lobby the decision makers and all of the government, and with our partnership with the different institutions, to keep the COVID service free for patients in all senses. We do have our gaps still in funding, but thankfully we managed to reduce, if not eliminate, the out-of-pocket expenditure for patients, moving closer towards universal health coverage. We also tried to build a staff roster of permanent staff to remove the issue that we chronically have of non-permanent staff. We want to move to a model where we have permanent staff with retention packages that are strong enough to keep them in place. So whenever there's a pandemic, we don't need to, or whatever other incident or disaster comes in, we don't have to scramble and look for new recruitment in the midst of the pandemic. So we're really trying to come up with packages of incentivization to our staff, whether they be training packages, whether they be financial or recognition, or opportunities for career development to help retain our staff, because we are plagued with very extreme high rates of turnover. Fortunately, also with COVID, despite the very high workload, despite the very high level of stress and the high degrees of burnout, we've managed to retain a lot of our staff that started with us, and we hope to retain the rest of them. And we really hope to prevent the issues of the regular health system from actually pulling into the COVID. And we hope that the COVID is actually, it's a disaster, but we hope it's a blessing for us for our health system to actually learn the lessons during the disaster and to actually implement those lessons across the board. Thank you.
Thank you very much, Dr. Omar, for these great insights. We are really proud that Sudan is the first country in the region that developed a hospital strategy. I mean, 2 years back, you have His Excellency the Minister and the team shared with all our member states the development in formulating a national hospital strategy. And I guess that strategy is paying off now in helping strengthening the hospital sector in Sudan. Of course, more needs to be done, but I believe that you are on the right track in that regard. Sudan has been very much, has always been, but at present, the situation is more acute, suffering from brain drain. Sudan has been producing a lot of good capacitors, but unfortunately, many of them leave the country, and there is a need to see how we can leverage and how we can bring people back, but also how we can leverage their expertise to support the national health system. I took note of what you mentioned about the limited number of staff at hospital level, having that the permanent staff are very limited and the others are on sort of temporary basis. Your reference to data is very important and very in the right place. I mean, all our countries have faced problems with data, and that's why we are leveraging. You refer to it as a blessing. We see it as an opportunity for building a better and more resilient health system for the future, how to strengthen the health information system, how to strengthen the data related to epidemics and to other challenges in the country. My last point about what you have shared with us is related to the critical care management training that you have undertaken. We are proud to be partnering with you on this. And I guess this is something that some countries have started, but it is something that would be useful for all countries in the region to benefit from. Of course, we know that Sudan, we are proud that Sudan is the first country that received the COVID vaccine, and now all our countries almost have it. So it's something to celebrate, and hopefully this will help us coming closer to the end of the current pandemic. You're referring to post-COVID. We hope to be living in the day where we talk about post-COVID. Unfortunately, it continues to be there, and we have to know how to cope with it in the coming future. With this, I would like to move to our Director of Program Management, Dr. Rana Haji, who is leading all technical programs at the regional office level and at the regional level. And my question to Dr. Haji is with regard to the WHO support to the hospital sector, and how does she see the current work that we are doing on hospitals, and how this can be better framed in the future to help build hospital resilience for the future, building on the lessons from the pandemic. Dr. Haji, the floor is yours.
Okay, great. Greetings, colleagues. Assalamu alaikum. And really, thank you very much for inviting me to this webinar, Awad, Hamid, Mirat, and the team. And thank you actually for the really nice panel that you have put together. I have been listening very carefully to all what you were saying, and it's really amazing to me, the amount of work and planning that has gone into place over the last year. I am myself, by training, I'm an infectious disease physician and an epidemiologist, and I can only imagine how many sleepless nights actually all of you probably had over the last year. So I would like to thank you first for all your service, but also for being with us today. And also to mention that I think, being an epidemiologist, I think what we have today is quite a biased sample of great hospital managers and directors who have really put a lot of thought into the process. I wish we have the same situation in many of our hospitals across the region. This is not the situation, as you all know, especially when we go to subnational level healthcare. And this is why I think it's really this area of improving hospital capacities is becoming more and more important in our overall preparedness and response to emergencies. So I've been listening to all of you, and it's really critical what you mentioned. I mean, the many areas, the many challenges you mentioned in terms of course, I think the one that stuck out is the importance of management and leadership and coordination. I think this is really very, very critical to the region. The importance of good training for infection control, for other, the importance of having better plans for preparedness and response at the country level, etc. And and also I can see that for some of our countries, for example, that have dealt with similar emergencies before, like what happened in the Gulf countries with MERS, for example, this has already prepared them more or less to the COVID situation, especially that at least on the infection control and the issues relevant to screening and triage and all of this, they were quite well prepared. So this is another important lesson learned from previous preparedness for other emergencies. So, Awad is asking really a difficult question. The reason it's difficult is because for years, and even for me, myself as a public health professional, for years, I don't think we have invested much on the public health side in hospitals per se, because hospitals typically are seen as part of a curative sector. We have traditionally worked with the preventive sector, mostly of ministries of health, and now the focus is completely changing even before COVID, because we are moving more towards strengthening health systems to allow us to better reach our universal health coverage goals. With the even under UHC, we are focusing more on primary health care. So I think this pandemic per se has highlighted the need to focus also on hospitals as very important part of delivering and ensuring we can achieve our universal health coverage. So just some couple of reflections. Here, even in the regional office, the hospitals as a unit or a team is relatively, it's a new group within our health systems department, and this is why we're very happy actually to have Hamid and his team to build that capacity within the regional office and to start exploring how we can effectively support hospitals in our region, because as I mentioned, we are still relatively small. So I think it's very important for us to get your feedback in terms of what are the key priorities for areas that WHO should work on that not too many others or other groups or institutions can work on. So defining our roles and prioritizing the areas to focus on is very important. I liked one of the comments by Dr. Al-Harthi earlier about the all being in the same boat. You're right. There are too many boats floating around. Unfortunately, not all of them, on the right track. But so I was thinking, what is our role? Maybe we can be like the mothership, or maybe the mothership role is something that is better taken by ministries of health. But I see our role, WHO, as the roles that had traditionally been assumed by WHO in terms of the normative guidance, developing guidelines, etc. Over the last few years, especially since the establishment of the WHO emergency program, we have taken a bigger role and a more active role in terms of overall preparedness and response. So I think this is another area where we can definitely also build on these capacities here in the regional office and partner with our colleagues in emergency departments to do more in terms of preparing countries to do that, to have better overall preparedness and response plans. We can also definitely do more in terms of training on management. Mid-level management was mentioned repeatedly. I think in our region in particular, this is an area, the whole area of governance with healthcare, whether it's at hospitals or other outside hospital setting, is an area that completely is one of the main building blocks of the strengthening health system, and that needs particularly a lot of support in hospitals. I mean, typically here in the region, we have, if we have good, strong technical staff, whether physicians or other, then we assume automatically that this would qualify them to be also good managers, which, as we know, is not an automatic thing. So I think focusing more on management and training is really critical. But also, I think the importance of doing good resource mobilization for hospitals to be able to have more flexible or resilient systems, as you've heard the word being repeatedly used. I think the resilience is really important, and we know that for hospitals to be well prepared, it's quite costly. I think Hamid commented earlier on. I had asked them a while ago, like, is it really cost effective? I mean, having worked in hospitals before, I know how much it costs to be really very well prepared and to have stocks of equipment and supplies and medications and others. And that's definitely something worth looking at, that we will explore more. But to give you an idea about the importance of overall, or the cost effectiveness of overall preparedness, globally, there was an estimate that the pandemic itself had cost the world up till now something like 11 or 12 trillions. And it's expected that there will be another $10 trillion at least in terms of the overall global cost of the pandemic, by the end of the pandemic or by the end of this year. But how much would it cost to actually be prepared? It is estimated that it only costs about $5 per person globally to be better prepared overall, hospital and other systems. So altogether, it will be about $40 billion for preparedness and response versus something like over $20 trillion in the estimated cost of this pandemic. So I think it should be a no-brainer, especially to policymakers, to encourage more investment into resources for hospitals that we need to work on hospitals. The other area where we've done quite a bit actually of training over the last year or so, year and a half, is infection prevention and control. As all of you mentioned, this has been one of the main challenges that all hospitals faced, whether in our region or globally, actually, with global shortage even of equipments and such as PPE and other. And I think this is also an area that we have been pushing even before COVID. It had shown already its importance during MERS, during Ebola outbreaks, for antimicrobial resistance. So I think we need to make sure that whatever we are doing, even in the context of the COVID pandemic, is more relevant to hospitals and to hospital systems across many other programmatic or disease areas in terms for better preparedness. So, I mean, I know I can go on and on. I wanted to also comment on what some of you mentioned in terms of the incident Management Command, because I think this is really important. And I was really happy to hear from Mrs. Hassan from AKU on what they did with the incident management. It's very, very important to have that. And this is how we have managed the pandemic here at the regional office. And that's how we have recommended, and also to the country overall, to have incident management support systems for management of the pandemic overall. And I'm actually curious that how many of you are part of national incident management commands, in terms, or how well are hospital, the hospital level overall, especially I think most of you are coming from tertiary level hospitals. How well are these hospitals represented on the national incident management commands, committees that are in place? So maybe I'll stop here, but as I mentioned, I think there are, I can think of like 3 key areas where we can focus on in terms of ensuring there are adequate and clear guidelines that are developed for the various elements of the response that you have mentioned, and make sure that these are disseminated. Training is already done on these. We can work more on preparedness and response for hospitals, so that their systems will be quite resilient and flexible. And there's already a curriculum that was developed here that we are starting to share and roll out in the countries for this purpose. And I think the overall training on leadership, on governance, basically leadership and management, which, of course, it's too much for WHO to do by itself, but there are many other resources. At least we can compile a long, list of resources and partners who can support us for these areas in particular. So one thing I didn't mention, but I think it comes obviously, is the importance of research. So WHO is a technical organizations, and I think some of the results of the survey that you heard already from Hamid and Mirat would be we need to have more of these. We need to have more data from the region. I would really encourage you all to write up your experiences, because there are lots of lessons learned for other hospital directors and managers in the region, but also globally. And I hope that also we will hear from you on what are the other areas of gaps in research that you think WHO can also invest more in and support you in this regards. So with that, I would thank you again, and look forward to have your comments during the panel discussion. Thank you.
Thank you. Thank you very much, Dr. Hajji, for this great insight and the commitment that you are making on behalf of WHO in support of countries building a more resilient, stronger, better prepared hospital sector, moving forward, and building on the lessons learned from the pandemic. You have referred to the importance of management, leadership, and coordination, which remains key. And we have been working on developing some capacity building activities in the area of hospital management. And hopefully we have been presenting it to countries. Hopefully more countries can benefit from those moving forward. I fully agree with your point about how the pandemic has emphasized and highlighted the work and the importance of hospitals in the health system. I mean, there has been some work done in the past, to give credit to colleagues working on emergencies in the past, to build more safer hospitals, looking at hospitals that are able to cope and to respond to catastrophes and emergencies, mostly man-made and nature-related emergencies, maybe less in relation to pandemics like the one that we are living through now, but also this idea that you have been promoting and colleagues from emergency program have been working on the all hazard approach. This is something that we need to further invest in the future. But I guess something that you touched upon and could be, it's a thinking, again, it might be linked to the point on research, is the nature of hospitals, how our look at hospitals for the future should change. Or will we continue to talk about the 20th century hospitals, or there should be different institutions that we refer as hospitals in the 21st century? Your last point about research, I mean, it is something that is very, very important. We need to document. I believe, personally, I believe it is our duty to the future generations to document these lessons, to distill the messages and lessons learned for the future generations moving forward. With this, we have concluded the great interventions, but by all our panelists. I know that Ms. Hassan is about to leave if she has not left. So I would like to thank her before she leaves us. She has another commitment, unfortunately. But Ms. Hassan, if you are with us, would you like to say any word before disconnecting? You might have already disconnected. So again, thank you very much, colleagues. There have been some questions that are raised on the that were shared with us by email. We started by almost 150 participants. We are now at 158. So I would really like to thank all colleagues who have stayed with us. We have received many questions, and I would like to share some of those to our panelists and to seek their further input into that. And if you allow me, I would like to start by Dr. Tabakkuli from Iran. And I would like to ask him the question about the role of the private health sector in providing COVID-related services in the context of Iran. Can you kindly share more light on this aspect of the role of the private health sector in the management of COVID in the context of Iran? Thank you very much.
Yes, it's social issues that we have in, especially in Tehran, because Tehran metropolitan city has a very different private sector and powerful private sector. For example, in Iran University of Medical Science, from 75 hospitals that manage with in university, and we have 45 powerful private hospital. That is a unique situation in Iran, in all of the Iran. So we have a commitment with CEO of these hospitals, and because economic states of some areas of Iran, of Tehran, with a supplementary insurance system, cover these patients. So with this agreement, we try to cover the private sectors. For example, one new hospitals that want to start working, we said to him that you are allowed only for COVID patient coverage. So all of this hospital covered the patient, and 100% of beds dedicated to COVID-19 hospitals. But this role, this regulation is not for all of the cities, because in some areas, in other parts of the Iran, there is no powerful private sector. So we try to dedicate one powerful system in hospitals system that cover the patient. So they have this commitment with the university, and from the EOC and from the system of the dispatching the patient, we covered we guide the patient for these hospitals if the patient have instant confirmation for trying to go to this type of hospital. So private sector was a very good cooperation with our hospital.
Thank you very much, Dr. Tabakkuli, for these insights about the private sector. We know that in Iran, as you mentioned, that maybe the private sector is not as prominent in the response, but we know that still a big part of health spending is going towards the private sector in Iran, and it is to see how we can really learn from the lesson, again, as Iran has always been doing, trying as part of the health transformation plan to improve financial protection. So how to secure that moving forward. But thank you very much for this very helpful response to that question. There's a question that is addressed to that team of researchers. So my colleagues Hamid and Meret, which reads as, will there be a second analysis to identify the factors and drivers that enable resilience and a better capacity to respond to unexpected shocks like COVID-19, for example, accreditation? Further and specific research is needed in this area. So Hamid, Meret, if you would like to shed light on this.
Many thanks for raising this important. And now still we are updating our information. We are looking for the updated research, and we are updating every 2 months the findings, and in order to enrich the information. Also, as we are going to present, as a marketplace presentation in our regional committee. So we are looking really for your contribution and further research. Since 4 months ago, we have seen several papers have been added that we have included in our update. So definitely we are going to improve it. And also accreditation, just we provided an example as well. WHO Patient Safety Friendly Hospital Initiative. We have seen, for example, in Oman, we do have 11 hospitals. They are at the grade 3 and grade 4, and they were much very well prepared and much more prepared than the other hospitals. So, and even some study in the Jordan, we have seen in the hospitals accredited, they have responded better. But it doesn't mean that accredited the only thing, or accredited is the gold key. Accreditation is one instrument, and we don't want to give the wrong message that that should be just accreditation, or we have other quality improvement approaches. But we have provided just this example as our participants, they clearly mentioned, and also in Jordan, in Oman for Patient Safety Friendly Hospital, in Iran for accreditation. So definitely you will see the further analysis. And please, if you have any report or any subgroup analysis or disaggregated analysis, you are most welcome to share with us, and we will include this information. Over to you.
Thank you very much, Hamid. Meret, do you like to add to this? So thank you very much to both. We have a question to Dr. Sabatine from Palestine, Augusta Victoria Hospital. And the question is, how did early and prompt supply chain management help your hospital to respond and provide services? Dr. Sabatine.
Yeah, I'm hearing, yes. I think it helped a lot us in dealing with the outbreak, as the safety of our staff was the priority also, because when you will save your staff, that means there will be somebody who can provide services for the patients themselves. So we collect all, most of all the PPEs in the market before the cases came to the or diagnosis of any case of COVID in the Palestine, and we were ready, and the safety of our patients, our staff was the priority. Our strategy was before, and when we set as a committee, was to decrease the prevalence, or to decrease the chance of having cases in Augusta Victoria Hospital close to zero. In order to do that, we also started to collect all necessary PPEs to protect our staff, and that helped us a lot. We never had any problem with PPEs among the outbreak at that time.
Thank you very much, Dr. Sabatine, for this. There's a question that I would like to address to Dr. Hajji, and it reads as follows. How can we build on COVID situation to develop and shift the practice and attitude of health professionals in regard to infection risk and infection prevention and control, IPC? Dr. Hajji.
Yes, actually, thank you very much, Awad, and thank you for the participant for this question, because this is exactly what we are trying to do. We are calling ourselves opportunistic, but if we don't do this now at a time where this area is under a lot of scrutiny and interest, we will never do it. So we have been trying for now many years to actually encourage this whole idea of overall preparedness and response. But typically what happens in countries is what we call the cycle of panic and neglect. During the acute incident, we are all panicking and running around, and then once things go back to normal, we just neglect some of these critical areas for various reasons. One of them is that they actually require quite a bit of investment in terms of resources, both human and financial resources. I think this really this is one of the main areas we are working on with the countries in terms of starting to think about, as you all mentioned, the post-COVID plan, or how do we benefit overall from the pandemic to because we have learned a lot over the last year. And one thing we learned definitely, I think the big obvious lesson is no country was fully well prepared. And then one of the big lessons was the importance of strong leadership and governance in terms of managing the overall pandemic. So I think for the whole area of infectious diseases, better risk communication, training on infection control is an area that we in WHO for sure we're going to be investing in and developing more systematic trainings. We are pushing at the highest level. Actually, we are pushing our countries to even to establish formal programs of infection prevention and control. When the pandemic started, we had actually official infection control programs at the national level in only about 8 of 22 countries in the region. So many of them, there were IPC programs at the hospital level, especially at hospitals that are tertiary and university-affiliated hospitals, but there was no strong program at the country level. So that's one of the areas we think all of our countries should do that, and especially now, as Awad mentioned earlier, I mean, we're not really starting from scratch, but that's not enough. We need a systematic approach. There's a lot about patient safety, but infection prevention and control covers patient safety as well as healthcare worker safety, as well as establishing the systems in place to ensure a broader approach to infection prevention and control. And this is not just for pandemics or emergencies. This is really the more even day-to-day thing is to prevent the common problem of healthcare acquired infections that contributes to a significant waste of resources in hospitals per se, but also to a lot of morbidity, additional morbidity and mortality for patients that could be preventable. So that's part of our overall plans for the recovery post the pandemic, and we started doing this with countries. We are encouraging many countries now to do what we're calling the interaction review, which is a review process that they do in the middle of the pandemic, because we're not out of it yet, unfortunately, but we will be out, inshallah, soon. And part of this interaction review is to identify the gaps, the lessons learned, and then key recommendations on areas of work that need to be strengthened at the level of individual countries. Thank you.
Thank you very much, Dr. Haji, for this. I'm cognizant of time. I'm trying to get as many questions as possible and try to merge some questions together. There's a question that I would like to address to Dr. Omar Yasin from Sudan, and it reads as follows: what do you think is the role of hospital sector in health systems recovery, especially in turbulent or emergency context? So, Dr. Omar, would you like to shed some light on this?
Yeah. Thank you. We are fortunate in Sudan that, as you mentioned, that we are one of the first hospitals in the region to have a hospital sector strategy. Having a strategy that accounts for disaster management and for surge response, and being proactive rather than reactive, as the condition has been with us historically, I think is going to play a very, very, very important role moving forward. Because COVID it was a stress test to the system. It really showed how underprepared and how unprepared we were. I think with a strategy that is comprehensive, that includes the lessons learned from this pandemic and from all of the disasters of the region, we will not be caught off guard, hopefully, next time when something comes around, which is inevitably going to happen, whether it's going to be a pandemic or a disaster of any other scale. Resilient hospitals with a good hospital sector strategy should definitely be the cornerstone of our response, and they will definitely guide us towards a more comprehensive response, rather than just trying to be reactive to specific conditions. I hope that answers the question.
Yes, that is very helpful. Thank you very much, Dr. Omar. My colleague Hamid would like to add something to this as well. Hamid.
Thank you. Very quick. We know that with the support of the European Union, there are some isolation center is being developed, and WHO is working for the development of the HR of these units. Really, it is some kind of collaboration between the different donors and also technical capacity and technical support of the WHO in Sudan. And we think the role of the hospitals within the integrated health services would be very important. So just I wanted to highlight, the technical support of and role of the WHO in technical support of even the new built hospitals or new built facilities, because the only thing is not the building the facilities, also the building the capacities and more resiliency is very important that we will work with Sudan, inshallah.
Thank you. Thank you very much, Hamid, for this. There's a question that is asked by Dr. Abdullah from Oman, and he's asking about nursing capacity in ICU. And he says that it has been mentioned that the nursing capacity in ICUs is very, very important. However, many developing countries have very low capacity of nursing care in ICU, which is impossible with short training courses. What is your practical solution for this to handle pandemics such as COVID-19? We have our regional advisor for nursing and midwifery, who is, I was trying to see if she's connected to the call. Dr. Arwa, are you with us? Or Dr. Gulen Jidek or Arwa Wais? No. Okay. Maybe I can shed some light from on this question. So we have been acknowledging the real importance of nurses. You would like to say something? Who was that? Arwa. Arwa, can you hear us? Yeah. Okay. If you can hear us and you would like to come in, please just shout. So what I was about to say is that we have been working last year, and I mean since some time, but last year we finalized a regional strategy for strengthening the role of nurses and midwives in the context of universal health coverage. Since then we have been working with countries to translate what has been endorsed as a call for action to strengthening the role of nurses and midwives. And now we are focusing more on specialized professions within nursing and midwifery, including ICU nursing. And this is something that will be coming up. In the call for action, we have identified 7 key functions or actions that nurses can need to work on. Some of those are directed towards policymakers, but also some are directed towards the professions. I fully take note of the importance of specialized nursing care, in particular in the context of ICU, and this is something that we'll be working on soon. Something that we will be launching very, very soon is the work that my colleague, Dr. Arwa Wais, if she can still hear us, has been working on, is an online course to shape the role of and contribution of nurses in the response to the pandemic. So we have identified some functions, and we are developing some capacity building training materials that will be disseminating soon for the benefit of all member states, for all hospitals and institutions in the region. Okay, with this, maybe. Yeah, Rana, please.
Yeah, just wanted to make a comment because I mean that was one of the things I didn't have time to comment on, the whole issue of HR capacity. Beyond, I mean, of course, the role of nurses is really important, and it was mentioned by some of our colleagues on the panel. But I mean, in our region, maybe not in the hospitals represented here, there is a significant shortage in many specialties that was also noted during the pandemic. I mean, for example, we were shocked. We did a lot of missions over the last year in many of our countries, and even some of our middle-income countries, for example, example, complained about enough doctors who are trained in intensive care, like intensivist. Also, many hospitals, for example, don't have really hospital epidemiologists, and often the infection control program is managed by an ICP nurse. So I think there are certain skill sets that are really critical for us, and I would like to highlight again, HR is one of the big issues that we also need to have a systematic approach to how to strengthen, and it varies a lot in our region, as you presented, depending on the socioeconomic level and the current status of their hospital systems. But even just coming recently from Sudan, I mean, we were very also much aware of how much shortage they have in terms of the specialized healthcare professionals in many of the hospitals. Thank you.
Thank you very much, Dr. Haji. And our last question is addressed to Dr. Harthi from Oman. So Dr. Harthi, you have frequently referred to the importance of communication across all staff and specialties and the collaboration across sectors. Can you please elaborate on the various mechanisms that have been used for that matter? Thank you.
Thanks for the question. Actually, it's a very important point. I don't think you can ever over-communicate the situation, and keeping your staff apprised of what the challenges and why are you making certain decisions is very important, because when they are convinced of why they are taking the sacrifices, they are more willing to sustain their role in that institution. Now, I think one of the blessings is that we have also had this pandemic during this period where technology has been a significant support in the communication. Unfortunately, technology is a two-edged sword. It's not a complete replacement to a face-to-face communication. Unfortunately, some things are lost in translation with just texting. The intonation, Zoom meetings, regular Zoom meetings between us and other institutions, as it was mentioned, I think in Pakistan, the consultation with other institutions, and especially those in regions that are far away that might not have the expertise that tertiary hospitals have. The capacity building, as we said, through technology is very important. The problem with communication is, unfortunately, the technology is also used to spread rumors and to spread false information. Sometimes half-truths are worse than actually complete falseness. So we just have to be careful about the communication, because also the communication is important with your staff, but also you having credibility with the public sector is very important. And the problem is that when you don't have an effective way of communicating with the public, there is a vacuum that will always be filled with those who call themselves doctors, those who call themselves experts, those we've found out a lot of organizations we've never heard of that always come up with studies that spread fear in the society. So it's a very complex matter. All I can say is that we have learned a lot in the last year and a half, and we continue to improve. It is important that the institutions also follow one message. I know that us as scientists, we like to debate issues, but when communicating with the public, it is important to have a unified message. Unfortunately, the public, depending on their background, might confuse debate to us not really knowing what we are doing. And that is why we can have as much debate as we want within the institution, but when we communicate with the public, we should have a unified message. I think these are just like the bullet points that I would like to mention.
Thank you very much. These are great bullet points. Thank you very much, Dr. Harthi, for this. There is a question that came in now, and I would like not to miss it. So coming from Professor Mansi. So he says that Suhair Mansi, I don't know if Suhair would be male or female. Yeah, Professor Suhair Mansi. So you are asking the question, you are saying that the challenges confronted by the different countries are nearly the same. How we can elaborate effort in the field of psychological support for healthcare professional team as equally to patients? And we have here also in the whole, our colleague, Dr. Gulen Jidak, was coordinating health workforce development in the regional office. So Gulen, would you like to shed light on this question?
Thank you very much. And thank you for this question, because it has been a very important and pertinent issue during the COVID-19. I mean, we had looked at three aspects of health workforce challenges. One is, of course, the increased workload and shortages came up. The second one is infection. But equally, the third one, with psychosocial well-being of the health workers, become very, very important during this period. And we have paid special attention, and together with the mental health program in our office, we worked very closely, and there has been significant efforts to address that. And all countries at the country level provided support. I mean, this psychosocial stress was coming out from several purposes. One is, of course, they were working on long hours under heavy workload. In any case, it creates stress. Second one, they were working under the risk of infection, with the fear of infection, and also with the fear of transmitting this infection to the beloved ones. So all this, and also they had to face some stigma coming from the community in the environments they live. So I think all this created a lot of stress on the health workers. So there were, and also they were trying to address an issue which is new to everybody, and the information was changing continuously. So I think there has been several interventions introduced by different countries. One of the most important interventions was communication. I think regular communication helped health workers to feel that they are not lonely, and they get updated information, they get the right information. In many countries, that helped quite a lot. Second one is number of countries in our region established telephone helplines to provide psychosocial support to their health workers, specifically for health workers. And also psychosocial support was provided in some of the health facilities in some countries. Another one is, of course, there has been further, to ensure further support, some psychosocial training was provided to some of the health workers, psychologists, some other people who can provide this. And of course, technology helped a little bit to expand that. But in short, I mean, I can expand these examples more, but for the sake of time, I think we can find quite a lot of examples, but we all know that studies are coming up now on the psychosocial distress of health workers. And in most studies, 30 to 50% of the health workers are reporting they face some psychosocial distress. So I think these interventions are becoming more and more important as the pandemic is going longer and longer. Thank you very much.
Thank you very much, Gulen, for this. More questions are coming. I'm cognizant of time. I would really like to apologize for not addressing them. There are very pertinent ones. There are several questions related to vaccine, but there is a question also related to hospital surveillance that has just arrived from Wahid. Maybe we can exchange on those after the end of the webinar. But before concluding, I just want to mention one word, and then I would like to hand it to Dr. Hajja to close the webinar. So I am a health economist by training, and one of the things that we have been working on for long was the question of efficiency in service in health system organization. And coming to the question of efficiency, we were talking a lot about how to increase the bed occupancy rate in hospitals, in order to be as efficient as possible. And countries were proud that they were reaching 90–95% of bed occupancy, which is great in terms of using the limited resources in the most efficient manner. However, when the pandemic hit, these countries found themselves with hospitals that were not able to cope with the surge in demand. I'm giving this example to say that our thinking nowadays in health system development have changed, and it will continue to change, building on the lessons from the pandemic. We would like to look at how we could develop health systems for the future that would cater for the goal of universal health coverage, which is very important, but also to that important goal of health security. And this is what we are trying to frame in terms of frameworks for health system development, for health system strengthening, and hopefully we'll be sharing more of that thinking with everyone in the coming future. With this, I would like to hand it to Dr. Hajj for the concluding remark. And if you can kindly mention something, I know it's unfair, but something about vaccines, because there are many questions about vaccines and how WHO and hospitals are supporting the ongoing efforts for vaccination. Thank you very much.
No, thank you very much, Awad. Of course, it's actually my pleasure to mention something about vaccines. So this is one of the most effective interventions we have. And, just next week, we're going to have it's World Immunization Week. Actually, we are celebrating World Immunization Week. So it's a very fitting time to highlight yet again the importance of vaccines, especially for this pandemic. And maybe one of the comments, and would appreciate the help of all colleagues, all healthcare colleagues, is that to help us really address the huge issues we are seeing in terms of the hesitancy, the infodemics, all the false rumors circulating in many of the countries. Many of these rumors, unfortunately, have been spread by some healthcare professionals who are not fully familiar, or they're maybe over concerned about the side effects without really doing that close risk benefit analysis. I think the key message for all of our participants, but also to help us spread the word about vaccines. We have been using vaccines now for over 70 years. We know they are among the most, if not the most effective public health interventions in terms of one single intervention. And we have now this hope of controlling the pandemic with the vaccines, although it's not by vaccines alone we're going to be controlling it. Definitely not this year, because we won't have enough people vaccinated this year. So we're going to need to have vaccine as part of a comprehensive approach. And would like to reassure people that despite the fact that these vaccines were developed in a record time, basically within a year, we went from vaccine discovery to vaccinating people, which has never happened before. We are still being or paying really extreme due diligence to the issue not only of vaccine efficacy, but vaccine safety. So vaccine safety for us is paramount, and and we're going through a very tedious process to assess the vaccines, to also assess whether vaccines should be given the emergency use listing authorization. Nonetheless, side effects, adverse events are going to be expected when we start vaccinating hundreds of millions of people, like what's happening right now. And these unfortunate, very rare side effects will happen. And the key message here is to be aware of them, not to take the vaccine. So be aware of the adverse events. It is still the benefits of getting the vaccines outweigh the risks that we are seeing, especially the serious side events. So that's my message. And there's no difference really between the vaccines, because these rare side events, we are starting to see them with all the vaccines that are currently available on the market. Okay, so that took me, again, completely different track. But I would just like to thank you again. Actually, Awad, you summarized very well many of the key issues that kept coming up, and hopefully this is really the beginning of the discussion. We need to have many more of these. We need to bring hospitals that may not be as fortunate. We know in our region, not all our hospitals have benefited from the same level of support, so that we have a more representative view of all the critical needs for hospitals and hospital systems in our region. But the feedback we received today, and we hope we will continue to receive from all of our dear panelists and participants, will be very useful for us in shaping our role at WHO in terms of how can we be more useful to you and more impactful so that we can help you better do your job, whether to control the COVID pandemic or many other pandemics and emergencies. So thank you again. Thank you very much for the team, for all the excellent preparations, and I look forward to ongoing dialogue and support. Thank you.
Thank you very much, Dr. Hajj, and nothing more to add. We started 5 minutes late. We are closing 6 minutes late, so apology for the delay. But wonderful panel discussion, wonderful participation, great questions. Thank you all, and looking forward to more activities of this nature moving forward. Stay safe. Bye-bye.